Very good morning to all students. Today we shall be continuing with the second part of Antiparkinsonian drugs. In the first part, we had discussed about the classification of Antiparkinsonian drugs, and we had discussed in detail about the main drug, that is dopamine precursor levodopa. In today's class, we shall be discussing about the remaining drugs which increase the brain dopaminergic system, and also drugs which decrease the brain cholinergic system. So we shall be starting with the first class of drugs, that is peripheral decarboxylase inhibitors. The examples of peripheral decarboxylase inhibitors include carbidopa and benzarafine. So in the previous class, I had told you that levodopa, about 95% of the orally administered levodopa is converted to dopamine by the peripheral decarboxylase enzyme. And this dopamine, which is present peripherally, it will be acting on the peripheral tissues. Only 1 to 2% is crossing the blood-brain barrier and reaching the brain, where it is converted to dopamine by the brain decarboxylase enzyme. And this dopamine is the one which is actually therapeutic, or which is the one which is acting at the site, that is the D2 receptors in the basal ganglia. So what these drugs do is that they inhibit the peripheral decarboxylase enzyme. As a result, the levodopa is not converted to dopamine peripherally. So more of the levodopa becomes available to cross the blood-brain barrier and reach the site of action. That is why the T half of the levodopa will be increased in the presence of these drugs, that is peripheral decarboxylase inhibitors. So carbidopa or benzarafine, they cannot be given alone, because if they are given alone, they will not be having any use. Their main function is to increase the levels of levodopa by decreasing its metabolism by the peripheral decarboxylase enzyme. So nowadays, levodopa is always given along with these peripheral decarboxylase inhibitors, mainly with carbidopa. The combination is often referred to as the Co-Careldopa. So this combination of levodopa and carbidopa has got several advantages. So one of the advantage already you know from the mechanism of action, that plasma T half of levodopa is increased. As a result, you can actually decrease the dose of levodopa to about 1/4 when it is given along with the carbidopa. Another advantage is that the peripheral dopamine concentration decreases, because there is no peripheral, not much conversion of peripheral of levodopa to dopamine in the periphery. As a result, the peripheral dopamine concentration decreases, and all the peripheral effects that were occurring because of the dopamine formed in the periphery decreases. One of which is that less nausea and vomiting and less cardiac complications. If you remember in the previous class, I told you peripheral actions of levodopa because of the dopamine formed peripherally is nausea and vomiting because of its action on the CTZ, and the cardiac stimulation, tachycardia, because of the stimulation of beta-1 receptors on the heart. Now this will be less when the combination is given. Also, the on and off effect in case of levodopa is minimized. This is because more amount of levodopa is present now in the brain, and as a result, dopamine levels are more sustained in the brain than when levodopa was being used alone. Also, it is seen that there is more improvement of the symptoms when the combination is given. It is also seen that the pyridoxine, it cannot cause a reversal of levodopa when it is given along with carbidopa. We had discussed in the previous class one of the drug interactions of pyridoxine and levodopa. So pyridoxine enhances the peripheral decarboxylation of levodopa and hence decreases its therapeutic effect. Now, in the presence of carbidopa, because this enzyme is inhibited, pyridoxine cannot enhance the degradation of levodopa by decarboxylase enzyme. This combination also has some of the disadvantages or drawbacks. that one of the major disadvantages is that we find more dyskinesias and behavioral abnormalities with this combination. So we had seen one of the adverse effects seen with levodopa was dyskinesias and another was behavioral abnormalities. Now this is seen to be more when the combination is given. It also is seen that there is excessive daytime sleepiness and more postural hypotension with the combination. Postural hypotension, I had mentioned in the previous class, is because of the central action. It is not the peripheral action, it is the central action. Now, because more dopamine is present in the brain because of the combination, so more postural hypotension is seen with the combination. Now, this is the tablet strengths which are available in the market. So you can see carbidopa 10 milligram plus 100 milligram levodopa, 25 milligram carbidopa plus 100 milligram levodopa, 25 milligram carbidopa plus 250 milligram levodopa. These are the tablet strengths which are present in the market. So you can see the combination is in the ratio of either 1:10 or it is in the ratio of 1:4. This was one of the questions that was asked in one of the university exams. The ratio or the strengths of the carbidopa and the levodopa in the combination tablet. So the ratio is either 1:10 or it is 1:4. Now we'll move on to the next class of drugs which increase the dopaminergic activity in the brain. These are the dopaminergic agonists. So the examples include bromocriptine, which is a Nergot derivative. This drug is no more used. It was earlier used in Parkinsonism, but this required large dose as well as it was not very well tolerated. So now we have got better drugs, dopaminergic agonists like ropinirole and pramipexole, which are better tolerated than bromocriptine. And the mechanism of action of dopaminergic agonists is that they stimulate the dopamine receptors present in the striatum. And they are more selective for D2 and D3 receptors, which are actually involved in Parkinsonism. They do not act on the D1 receptors. It is the D2 or the D3 receptors which are mainly involved in Parkinsonism. And these drugs are more selective for D2 and D3 over D1 receptors. Now, one of the advantages of this class of drugs is that they are effective even in advanced cases of Parkinsonism, where there is a loss of dopaminergic neurons. So in the last class, I had told you that the on or off effect or the wearing off effect of the levodopa occurs mainly because there is a loss of the dopaminergic neurons with the progression of the disease. As a result, the levodopa cannot be converted to the dopamine in the nerves and it cannot be released. So even in such patients where there is a loss of dopaminergic neurons, these drugs can be used because these drugs do not require any conversion to dopamine. They are actually acting directly on the D2 receptors and stimulating them. So this is one of the advantage of these drugs. They can be used in advanced cases where there's a good amount of degeneration of the neurons. They are rapidly absorbed orally and they undergo extensive metabolism and they are excreted in urine. They have got a T-half which is much longer than that of levodopa. It's about 6 hours. Then the adverse drug reactions include nausea, postural hypotension, behavioral problems. And these behavioral problems are very, very specific or very peculiar type of problems. You can see here, impulsive shopping, betting, gambling, inappropriate sexual overactivity. All these are some of the abnormal behavioral issues that are seen with the use of these drugs. Even hallucinations and excessive daytime sleepiness can be seen as an adverse drug reaction of dopaminergic agonists. Now, what is the status of use of these drugs in Parkinsonism? So they can be used as monotherapy in very early cases of Parkinson's disease, or they can be supplemented along with the levodopa and carbidopa in the case of in advanced cases. So they can be either used in monotherapy or as adjunct therapy. They also have got some additional neuroprotective effect And it is seen that when they are given along with the levodopa, they are supposed to be decreasing the incidence of dyskinesias, and there is less of honor of effect and more length of symptom-free life is seen. These are some of the advantages of this group of drugs. One of the other uses of this group of drugs is that they are used in restless leg syndrome. I'm not describing this restless leg syndrome. It is given in described in your KD Tripathi 8th edition, page 458. So the interested students, they can read out the symptoms of this disease from that page. Okay, so we'll move now on to monoamine oxidase B inhibitor. The examples include selegiline, the other name is deprenyl, and the other example is rasagiline. So the mechanism of action of these drugs is that they are selective and irreversible inhibitors of monoamine oxidase B. Now, I think I have already described about monoamine oxidase enzyme in the previous class also. So once again, let me remind you that monoamine oxidase enzyme exists in two isoenzyme forms, that is A and B. And both these are present in the peripheral adrenergic structures and intestinal mucosa, but MAO-B is predominantly present in the brain. And MAO-A and MAO-B, when we compare them, the MAO-B metabolizes dopamine preferentially, whereas MAO-A can be acting more on the other catecholamines also. But the monoamine oxidase B, it preferentially metabolizes dopamine over the other catecholamines. So these drugs, they are selective and irreversible inhibitors of MAO-B. So they inhibit the degradation of dopamine in the brain. As a result, they increase the availability of dopamine in the brain. At the same time, they will not cause much of the accumulation of the other catecholamines, because I told you monoamine oxidase B is mainly acting on the, is mainly metabolizing the dopamine and not the other catecholamines. Now, when we compare rasagiline with selegiline, rasagiline is found to be more potent. It is more longer acting, and so only once a day dose is enough. It also has got less adverse effects and drug interactions as compared to selegiline. So we prefer rasagiline over selegiline in the treatment of Parkinsonism. Now, the common adverse drug reaction of these group of drugs are nausea, postural hypotension, then behavioral problems like psychosis, dyskinesias. Then with selegiline, we can have even insomnia and agitation. The reason for agitation is that selegiline is converted or metabolized to amphetamine, and amphetamine is responsible for agitation and insomnia, which is seen with selegiline. This is not seen with rasagiline. Also, selegiline has got lots of drug interactions. The most notable one is that with pethidine. So it increases the metabolism of pethidine to norepinephrine, and norepinephrine can cause excitement, rigidity, hypothermia, and respiratory depression. This selegiline is also seen to have drug interactions with other drugs like tramadol, tricyclic antidepressants, and selective serotonin reuptake inhibitors, which are antidepressant drugs, which you will be learning later. Now, what is the status of use of these MAO-B inhibitors in Parkinsonism? So they are mainly used as adjunct to levodopa, and they help to reduce the levodopa dose to 1/4 of its original dose. They also, like the previous one class of drugs, that is dopaminergic agonists, have got additional neuroprotective effect. But the problem with this drug is that when we are using it with along with levodopa in the advanced cases, it is seen that it increases the dyskinesia and by behavioral abnormalities of levodopa. So that is one problem. That is when we are using in advanced cases where we have to use the full dose of levodopa, this combination of this drug seems to be increasing the dyskinesia and behavioral abnormalities seen with levodopa. Now, effect of selegiline is also very short-lived. It is only 6 to 26 months. Because of these two drawbacks, it is less preferred. It's a less preferred drug. Now let us move on to the next category of drugs, that is COMT inhibitors. The examples include an entacapone and tolcapone. So I already have mentioned about the role of COMT. So we'll revise it once again. COMT enzyme metabolizes levodopa to 3-O-methyl-dopa in the periphery. It also metabolizes dopamine in the brain. These are the two actions of COMT which you should be knowing. So what will the COMT inhibitors do? The COMT inhibitors will inhibit the COMT in the periphery. As a result, what will happen? The levodopa will not be metabolized to 3-O-methyl-dopa, and this will increase the T half of levodopa and allows a larger fraction of the dose to enter the brain. So we have seen that levodopa is metabolized in the periphery by decarboxylase enzyme as well as by the COMT. So peripheral decarboxylase inhibitors that we studied previously, that is carbidopa and benzodiazepine, they increase the levels of levodopa that can cross the blood-brain barrier by decreasing the decarboxylase enzyme. But there's another enzyme that is COMT, which can also metabolize. So even COMT, if we block, then we can have more of the levodopa entering the brain for its action in the basal ganglia. So the COMT inhibitor in the periphery, it will make more levodopa available to the brain. Its inhibition in the brain will cause more, will be preserving dopamine levels in the striatum, because more dopamine will be available as the degradation will be inhibited. Now we have got two examples, tolcapone and entacapone. Of these, tolcapone has got both peripheral and central actions on the COMT, whereas entacapone acts only peripherally. The adverse drug reactions include nausea, diarrhea, postural hypotension, dyskinesias, confusions, and hallucinations. Tolcapone can produce fatal hepatitis and rhabdomyolysis in rare situations, and because of this reason, it has been banned or taken off from the market in many countries, and in some countries, it is prescribed in patients only after their informed consent. The status of use in Parkinsonism is that they are used only as adjuncts to levodopa carbidopa combination in advanced cases of Parkinson's disease. So when you are giving these three drugs together, that is levodopa, carbidopa, and the entacapone, so we can see that the levodopa is not at all converted to dopamine or other metabolites in the periphery. More amount of levodopa is now available to cross the blood-brain barrier to reach its site of action. Now we go to the next class of drugs, that is the dopamine facilitator, or otherwise the NMDA receptor antagonist. Example includes the amantadine. So this drug facilitates the synthesis and release of dopamine from the dopaminergic neurons in the brain. It is also an antagonist on the NMDA receptor, which is a type of glutamate receptor. It decreases the glutamate neurotransmission in the basal ganglia, which can have a beneficial effect in Parkinsonism. So in the previous class, I had shown you a picture of with having many circuits, and I had shown you that the outflow from the striatum to the basal ganglia can be either by the direct pathway or the indirect pathway. So in the indirect pathway, we had seen a glutamatergic pathway, and because of that action, you can see here the antagonistic action on the glutamate receptor. It can be beneficial in the case of Parkinsonism. However, the action of this amantadine is not very well known. At this point, I would like to say that amantadine was actually discovered as an antiviral drug used for influenza, but later on it was actually serendipitously discovered for the treatment in Parkinsonism. So it is only used for initial treatment in mild Parkinson's disease, or it is only given as a short course to supplement levodopa for advanced cases. It is not continued for a long time. The reason being that the tolerance develops to its therapeutic effect in some weeks, and also it is less efficacious as compared to levodopa. For these two reasons, it is not a very popular drug. The adverse drug reactions include nausea, hypertension, constipation, dry mouth, insomnia, headache, heart failure, and a particular adverse effect called as a libido reticularis, that is the bluish discoloration of the skin. Now we come to the last part of this class, that is central anticholinergics. So far we have discussed the drugs which increase dopaminergic activity in the brain. Now we'll go and we'll go on to the next group of drugs that decrease the cholinergic activity in the brain. So these include trihexyphenidyl, otherwise called as benzoyl, procyclidine, and piperidine. These drugs have got higher central to peripheral anticholinergic action. I hope you remember the prototype drug of anticholinergic action, that is the atropine. So these drugs, they have got a higher central anticholinergic action as compared to the peripheral action. They act by reducing the unbalanced cholinergic activity in the striatum of Parkinsonian patients. So I had already told you in the first class that's an imbalance between dopaminergic and cholinergic activity in the brain of the Parkinsonian patient. And these are drugs that are acting by reducing the cholinergic activity in the brain. Now, they are less effective than levodopa, but they are cheaper and better tolerated. They are used alone in mild cases or in cases when levodopa is contraindicated. They can be used in others along with levodopa also. So they mainly relieve the tremor and rigidity, but they do not have much effect on the hypokinesia. Their adverse drug reaction includes mainly the anticholinergic effects, that is the atropinic effects like dry mouth, constipation, blurred vision, urinary retention, confusion, and all. So we have got one very important thing that we should always remember, that central anticholinergic drugs are the only effective drugs in drug-induced Parkinsonism, where levodopa is ineffective. So I had mentioned in the beginning of the chapter that the Parkinsonism, the main causes are Parkinson's disease and the drug-induced Parkinsonism. So we have seen that the central anticholinergic drugs, they can be used in mild cases of Parkinson's disease or in cases when levodopa is contraindicated. In others, they can be used along with levodopa. But so far, we have not discussed any situation where regarding the drug-induced Parkinsonism. So far, all the drugs that we have discussed, they were not effective in drug-induced Parkinsonism. These are the only drugs, the central anticholinergic drugs are the only drugs which are effective in drug-induced Parkinsonism. So I had given some examples of drugs which can cause Parkinsonian symptoms, that is phenothiazines, which are a group of antipsychotic drugs, and metoclopramide. So in such cases, you have to give central anticholinergic drugs. Levodopa will be ineffective. Now, why is this so? This is because these drugs, that is the phenothiazine antipsychotics, they block the D2 receptors, and they block the D2 receptors, and hence if you give the levodopa, so levodopa will not be able to act because the receptors are blocked by these drugs. So we have to do the alternative, that is, since we cannot increase the dopaminergic activity, we will try to cut down the cholinergic activity, and that we do by anticholinergic, centrally acting anticholinergic drugs. So when you study the antipsychotic drugs now in the coming days, you will see that these drugs, that is the phenothiazines, they produce their antipsychotic effects by blocking the D2 receptors in the limbic system, and the Parkinsonian adverse effect is produced because they block the D2 receptors in the striatum. Now that is the reason why if you give levodopa in cases of drug-induced Parkinsonism, you will not get the effect, because levodopa will require the D2 receptors to be there, but these are blocked in the case of phenothiazines or metoclopramide. Hence, we can only have the option of cutting down the cholinergic activity so that both the dopaminergic and the cholinergic activities are balanced. We had also mentioned central antihistaminics in the classification. So these antihistaminics also have got central anticholinergic action, which can be beneficial in Parkinsonian patients. They also produce some amount of sedation, which can be of benefit especially in elderly patients. So with that, we conclude this topic. But before we end, we'll just go through some of the important questions. That is, classify anti-Parkinsonian drugs. Levodopa is an important short note. You can be asked about the merits and demerits of Co-Careldopa, or you can be asked what is the rationale of giving carbidopa or benzodiazide with levodopa. So you have to mention the benefits of combination of the peripheral decarboxylase inhibitors with levodopa. Which is preferred for levodopa-induced vomiting is a domperidone metoclopramide, and why? I have given you the answer in the previous session. Then dopamine agonist, that can be asked as a short note. MAO-B inhibitor can be asked as a short note. Any of the drugs, that is saligerin or rasagirin, can be asked singly. Drug interaction between saligerin and pitherin, which I had mentioned today, can be asked. COMT inhibitor can be asked as a short note. And drugs, name the drugs for treatment of phenothiazine-induced Parkinsonism, or name drugs for treatment of drug-induced Parkinsonism. This can be asked. The answer is central anticholinergics, and you have to quote some examples like trihexyphenidyl, procyclidine, and biperidine. Why is levodopa not useful in drug-induced Parkinsonism? I just gave you the answer. The answer is the D2 receptors are blocked, hence levodopa cannot be given. We have to give centrally acting anticholinergic drugs to cut off the cholinergic activity and hence to balance both the cholinergic and the dopaminergic activity. So just revise the topics, and let me know if there are any doubts. Thank you.